Hello and welcome to PCR webinars in 2025. My name is Goran Stankovic and I wish you and your families happy and prosperous New Year. Today we will discuss kissing balloon inflation in left main and non-left main PCI, and we have great team. I have with me in studio Professor Jens Lassen and Professor Jacek Legutko, and we have Professor Bong-Kwon Koo remotely connected, and I wish you also happy and prosperous New Year. Our goal today is to discuss the role of systematic side branch intervention in provisional stenting, not in two-stent strategy. We know that in two-stent strategy, kissing is mandatory. And we will discuss in depth the KISS trial results and the impact of this trial on our clinical practice. And we'll, of course, try to learn how to optimally perform kissing and explore potential pitfalls using the insights from the Visible Heart Lab. I know that kissing balloon inflation is very delicate and very sensitive procedure. So even if you make small procedural mistakes, it will impact on the procedural result and it will impact on patient outcome. And I got the idea for the title from Albert Einstein, who said, "Any man who can drive safely while kissing a pretty girl is simply not giving the kiss the attention it deserves." So our goal today is to give attention and to help and discuss with our colleagues how to optimally perform kissing, and first of all, whether we should do kissing or not. There are many reasons to do it. So we have better rheology, less side branch occlusion, less periprocedural injury, less angina, less restenosis. But also people favor not doing kissing because procedure is shorter, there is less exposure, less radiation, lower risk of side branch dissection, lower need for the second stent, and of course, impact on the risk for restenosis. So I'm presenting KISS trial on behalf of PI Bernard Chevalier and the KISS study investigators. These are my conflicts of interest. And what is important for this study? It was focused on non-left main all bifurcation lesions except 001. And what is also the key, they systematically perform, according to European Bifurcation Club recommendation, proximal optimization technique. And if after POT, side branch was patent, no flow reduction, and no sign of ongoing ischemia, they randomize patients to no side branch intervention versus side branch intervention, whether it's kissing balloon or POT side POT. Primary endpoint was the rate of periprocedural infarction or injury using ARC2 definition within 48 hours, increase of 70 times troponin, the upper limit of normal, or 35 times plus the additional criteria. Secondary procedural endpoints, technical success, acute gain, procedure time, X-ray exposure, and secondary clinical endpoints, target lesion failure, with individual components and definite or probable stent thrombosis. These are the baseline characteristics: 303 patients with no side branch intervention and with intervention 314. As you may see, mainly no difference in baseline characteristics except for slightly different rate of previous MI and previous PCI. When we speak about procedural characteristics, very important message is that by QCA, side branch reference diameter was 2 millimeters and side branch lesion length was 4.4. So relatively small side branches with short side branch lesions. These are the main procedural characteristics. There was clear reduction in procedural time by 24%, saving contrast media volume by 13%, and less X-ray exposure by 28% if we don't do side branch intervention compared to control group. And there was the primary endpoint, which was non-inferiority and was achieved. There was no difference in the rate of periprocedural injury and infarction in two study groups. If we go to 30 days and if we go to 1 year follow-up, we see really very low rate, 3.6% at 30 days target lesion failure, only 5% at 1 year. In the control group, 4.5% versus 6.4%. And again, in the components, there is no difference individually between no intervention versus control group. So why this study is important? Because based on these results, provisional stenting in routine non-left main bifurcation using the Resolute Onyx drug-eluting stent was associated with good short and mid-term outcome. No-touch strategy is non-inferior at 30 days compared to systematic side branch intervention, and was also safe and efficient at 1 year. Of course, what we are looking for is a left main bifurcation study that we need to plan. And now I want to hand over to my colleague and friend, Professor Bong-Kwon Koo, with one of the largest data sets discussing simple crossover stenting versus side branch opening. Kwon, please take the control over slides.
Okay, so thanks, Goran. So I'd like to talk about the data from COBIS III registry as presented by Goran. It's comparison between simple crossover stenting versus side branch opening. This is my disclosure, and I'd like to give a brief introduction for the COBIS registry, which is investigator-initiated and nationwide multi-center registries for coronary bifurcation lesion. And today I'm going to talk about COBIS III trial, which enrolled around 2,500 patients. And study enrollment period is 2010 to 2014, and we included only the very large side branches, 2.3 millimeter or larger by the QCA. And in COBIS III, we included left main and only included a second generation drug-eluting stent, and median follow-up duration was quite long, 53 months. So we previously published the data on the prognostic implication of KISS, and it's interesting to see the results were different in the previous COBIS trial. COBIS I, kissing had a bad impact on the outcome, but COBIS II, kissing has a good impact on the outcome. So the question still remains whether KISS is still good or bad. So in this study, a sub-study from COBIS III trial, we tried to compare the outcomes of those who underwent the side branch opening versus a simple crossover stenting. For that, we excluded the patients with 2 stenting strategy and divided the patients finished with the only 1 stent strategy into the simple crossover 1,600 patients and side branch opening, which includes the simple opening and the kissing balloon inflation. And the primary clinical outcome in this sub-study was 5 years target lesion failure. So baseline characteristics similar to other intervention trial, mean age 63, male dominant, hypertension 60%, diabetes 33%, and different from the KISS trial, 2/3 of our enrolled patients' initial presentation was acute coronary syndrome. And what is more interesting is that the lesion level characteristics, as I mentioned earlier, this trial included the patient of left main, and in the side branch opening group, this is registry, not a randomized trial, higher frequency of left main than in side branch opening than simple crossover, and true bifurcation was also higher in side branch opening group, 36% versus 58%. For the QCA, which is important, is for side branch reference diameter, as we included the left main. In this study, the side branch reference diameter was around 2.6, but the lesion length was rather small, 4 millimeter in simple crossover and 5 millimeter in side branch opening. And in the side branch opening group, kissing balloon technique was performed in around 77%. And this trial, the patient was enrolled quite a long time ago. POT technique prevalence was quite low, around 30%, and IVUS was used in around 40% in both groups. So this is the main outcome of our trial, target lesion failure, a composite of cardiac death, target vessel MI, and TLR. During the 5-year follow-up, there was no difference between the simple crossover and side branch opening group. And this is individual endpoint, cardiac death, target vessel MI, and target lesion revascularization, there was no difference. And also, no difference was found in all outcomes after IPTW adjustment. We also did the subgroup analysis according to the clinical presentation, and also the important subgroup may be the left main versus non-left main and true or non-true bifurcation. And as you can see here, there was no difference in clinical outcomes between simple crossover versus side branch opening. But we know the limitation of trial very well. This is a retrospective observational study, and the choice of treatment, IVUS, etc., was done by the operator's discretion. And again, pot rate was low, and we excluded two stenting cases, and most of those patients are relatively simple bifurcation lesion. However, on top of KISS trial, I would say that the long-term clinical outcomes of simple crossover stenting without side branch opening was acceptable compared to the additional side branch opening, which was true also for the left main and true bifurcation lesion. So from our trial, we had an insight that an additional routine complex procedure for side branch opening may not be mandatory after main branch stenting for bifurcation lesion. But this was a registry data, and we have a very nice KISS trial. And another news is that we have an ongoing randomized trial, which will enroll the significant drill side branch lesions, 1,000 patients, and randomized into simple crossover versus side branch opening. And we are running this trial. And at this time, we have enrolled around 30% of the patients. And I hope to share this randomized trial results soon in near future. Thank you.
Thank you very much, Dr. Ku. Fantastic data. I have to share that I attended the ENCORE Seoul for the first time last year. It was really very pleasant experience when you present data. You actually have your own studies, all randomized, adequately powered, so when you recommend something to the audience, you can really base on your own data, and really congratulations on fantastic effort and the leadership in the COBIS group. If you have any questions, Jens, you participated, probably one of the people who designed Nordic 3, Nordic KISS. This was also for us shocking at that time. No difference, and up to 5 years, some higher rate on non-cardiac mortality after kissing. Can you comment? What is the perspective, the echo in the Nordic countries?
Well, the echo is that it's a while ago, and it was first generation drug-eluting stent we used in those trials, which was thick stent struts, and POT wasn't invented. So actually at that time, we just stented across the side branch and randomized between kissing and no kissing. And even though we did that, and even though the Nordic 3 may be a bit underpowered, there was not a real difference in the two groups, which is interesting. But we need to underline very clearly that the side branch was small, and the lesion length in the side branch was well below 5 millimeters. So again, it supports what we have seen here, but also with the older stents.
Thank you. There is a question for Professor Ku, and I really would like to encourage you to ask questions. You know that in bifurcation webinars you can ask absolutely anything. We'll be happy to discuss it with you. From Harrison Go, dear Prof. Ku, it seems there is separation of the curve in the left main group. Perhaps left main subset may have benefit if the number is larger?
Yes, so it's true that there's a separation, but in that curve, actually, the event rate numerically was higher in side branch opening group. And I think it is due to the baseline characteristics difference in those groups, but that does not support the benefit of side branch opening even in the left main group.
Yeah, and I have to mention also, because everybody knows I was trained with Dr. Antonio Colombo, and he is one of the teachers that I learned most what I'm discussing today. Milan-Tokyo registry actually is the replica of your data. At 5 years of follow-up, two experienced centers, very experienced operators, no difference in clinical outcome in left main crossover stenting, whether or not opening of the side branch was performed. So difficult task for three gentlemen today to try to individualize the approach. Maybe we should start with the first case. Jens, provisional LAD diagonal. Please present your case and then we'll try to discuss together.
Well, thank you, first of all, for an excellent setup for having this discussion on what to do clinically and what to do if we have a patient in front of us and have to make personalized medicines and personalized decision. Of course, these are made on top of the knowledge we have from registries and from randomized trials, but still there is many considerations to take into account. And I'm very happy to share with you a case, 57-year-old male. We know on beforehand that he had a stent in the proximal LAD in early 2020. And we also knew that the CERT has a takeoff from the proximal RCA, so it's actually a singular LAD on the left side. We also know that he's extremely physically active. He plays old boy football, and they really go for it, and he played tennis twice a week. And on top of that, he biked 250 to 300 kilometers a week all around the year in the Nordic countries. So he's extremely physically active, and he was able to be that for 2 and basically 3 years after the stenting. But then he started having effort angina, and it continued to worsen. And for unknown reason, he was submitted to a coronary CT angiography. This is not really what we are doing in these cases because we know there was a stent before, but we did a CT angio. And we know that the echocardiogram showed us he had a very well left ventricular function and no regional wall motion abnormalities, which was actually pretty obvious from his physical state. This is the CT scan. And as you can see, it's actually a very good quality, and quite surprisingly, his stent was doing very well. I have to say that the first initial stenting was done like a provisional stenting, just with a pot without a kiss. So this is the result 3 years out of that procedure. But as you can see, there seems to be a severely narrowing just below the lesion. And if we make the reconstruction, it's pretty obviously what is going on. Nice stent result, but poor distal result. And here we have the angio. On the left side, you see the right coronary normal and the circumflex takes off. And on the right side, you really see the procedure as it is. And from another angle, you can see that the stent result is nice, but there is some problems distally. And maybe we should move to the...
I think we can use the smart board. Yes. I like smart board very much because it really gives you the opportunity to in-depth analyze the angio. So
exactly,
we have
Goran. And here,
two still frames.
Yeah. Here we actually can see that below the stent, we do have a true bifurcation with a Medina 1, 1, 1, and we will actually go a little bit deeper into that. But there is a second diagonal with a pins in the opening, and there is a third diagonal which might be diseased as well. And if we take a look in the other frame, we can see that there is disease in the areas.
Yeah. So we have 1, 2, 3 diagonal branches.
Yes.
The first one is inside the stent. Second one is actually in the area of interest.
Yeah.
It's really in the new lesion at the distal edge of the stent. And the small third one. If we follow Professor Koo and what I learned from him, and I like to hear his comment, Kwon, if we have 3 diagonals, probably likelihood of having one which is clinically significant is very low.
Yeah, that's so true. So that it's interesting that if we judge this branches only by the vessel diameter, I think that the second diagonal seems to be a very significant, and some may consider it too stenting. But as you can clearly see in the smart screen, there's 1, 2, 3 diagonal branches, and if you estimate the territory, it is very difficult for that second branches to supply more than 10% of myocardial mass at risk, if that's the true definition for clinical relevance. So that in this kind of images, it's very important to simply estimate the territory, not judged by the vessel diameter or the length alone.
Yeah, and also with Jens, we try to draw the contour of the vessel as well as the plaque distribution. Jens, it's your drawing. Please help us understand.
But as you can see in the proximal area around the second diagonal, we do have the plaque distribution exactly where we normally see it in a bifurcation. We can speculate why it comes, because in the original angio there wasn't any. So it could be a geographical miss in the first procedure that actually may have increased the risk of late restenosis and plaque distribution. And we also do have some plaque around the third diagonal, but also a little more below that, which means that the area of interest is pretty long. It's extended out of the stent, and it actually includes both the branches.
You know what is the most surprising for me? 200 kilometers a week.
Yes, with that.
With that.
250 actually, yes.
250.
Yeah.
Sorry.
And only severely diseased or actually impaired in the last 6-8 weeks.
Okay, Jacek, what do you think? Anything else to add?
No, I believe that we have just the bifurcation lesion, which has to be treated with provisional stenting strategy first. We need to protect this diagonal branch with the wire, but personally, I would then predilate. If I have acceptable result on the side branch, I would not predilate the side branch, but just go for stenting of the main vessel, followed by POT, and then decide whether I need to do the kissing balloon inflations at the end or not. If I have a good result on the side branch, good flow, I would skip it. In the non-left main bifurcations, I would not go for systematic kissing.
So no systematic kissing
for non-left main.
Upfront decision to go for provisional.
Yeah.
Yes, are we close to your decision
We are very close to my decision. And as you know, I always start procedures in a provisional way. And then I actually do it stepwise, exactly as Jacek is telling us.
Can you please take the slide?
Yeah, we can actually move on.
Yeah, and we move on to see the results.
So start provisional and, of course, protect the side branch with a wire. Just to remember the steps in the provisional stenting, when the stent is inserted, it's with respect to the distal diameter, not the proximal. And that is extremely important not to actually push the carina towards the side branch. The next step is actually the proximal optimization technique, which opens the stent slots towards the side branch and make a proper realignment of the stent in the proximal part because the diameter is larger there. We'll come back to that. Then there is the other steps if we move on. But those two steps are the first steps. So I didn't predilate. I actually used a no-touch technique. I wired the side branch. I predilated the main branch, but not the side branches. And I predilated with a little bit smaller balloon that I expected not to make too much plaque shift before I brought in the stent. And there was some tricky thing that needs to be considered here, because when we stent over the two side branches, the second and the third, and have to realign the stent within the old stent, which was already there, we need to do some extra post-dilatation. And that post-dilatation needs to be done in a pot way, where you do it stepwise, pot each segment by its own, and not covering the next step before you have a larger balloon. Otherwise, you may hamper the side branches. So there's a lot of technical issues in this. And this was what we did. We brought in the stent, we stented it, we made the pot, as you can see on the left technique. And then again, jumping back to the visible heart lap. This is what it looks like when you have implanted the stent with respect to the distal diameter. And it will be floating. And it's a crucial step. This is just before the pot. And after the pod, we'll have, as you can see, a proper, in this case, alignment of the stent with the vessel wall and a larger stent in the carina area. Like this in the micro CT from the pig heart, you can see that in the takeoff of the side branch, there is, just because of the pod, a more open stent struts area, which is important. This is not a kiss, this is just a pod. So, again...
Jens, sorry, I have to interrupt you. Bogdan Janusz is asking why you don't protect the first diagonal during pre-dilatation.
Well...
You protected, of course, the second one.
Yeah, well, that's actually a good question.
Thank you, Bogdan.
Yeah, well, the reason for not doing it was actually out of the CT angio and the initial angio. There was no disease in
Fully
the area
patent, no disease at the ostium,
Yeah.
excellent result. Yeah. Okay, perfect. Are there any physiological tests, FFR, IFR, performed to see if the stenosis cause of carina shift in the side branch with TIMI3 and no pain is significant or not? I think we stop here. Result is already great. I need to use again Professor Ku because I learned from him. So, Prof. Ku, Dr. Manukian is asking, should we do now at this point FFR, IFR to see if the stenosis in the side branch is significant or not?
Yeah, I think that's a interesting and important question. But in the beginning, I found that the side branch osteal lesion is quite severe. And at this stage, after POD, I saw that that lesion seems to be a little bit less. But the question is, if you think that you are not ended up with the kissing, just leave it alone. I think it's fine because even though FFR is low, there will not be a kind of significant impact on the outcome. But if you really want to do an ischemia-based revascularization, physiology may be needed. So I'm wondering, so if I measure I prefer FFR, but the NHPR can also be used, but if I measure the FFR for that lesion, maybe it's around 0.75 to 0.85 borderline.
Thank you. I think it's a good moment also to make a general comment on the role of physiology in the main vessel and the side branch. We worked together, Korean, Japanese, and European Bifurcation Club for more than 3 years on fantastic consensus statement. And you were the leader of the project, really true leader of that one. And what I learned from that one is that if we have disease in the main vessel, it's inaccurate to perform assessment of the side branch before stenting the main vessel. Can you please elaborate on that one?
Yeah, so if this is, for example, supposing that there's a true bifurcation lesion 111, and if you measure FFR, especially FFR at the side branch, it's not a side branch FFR, but the main plus side branch FFR. But if you use the NHPR, IFR, or other non-hyperpressure ratio, that interaction may be less. But generally, if you are handling with the true bifurcation lesion, it's a continuum of the main and side branch, and it's very difficult to discriminate true main physiological significance and side branch significance. And that's one of the reasons why we do not strongly recommend to measure side branch FFR before main branch intervention, and for example, main branch stenting, because that there is an interaction, or when you measure FFR at the side branch, it's not a side branch FFR or NHPR, but a combination of both main and side branch.
Thank you very much. Jens, I think you can show the rest of the case.
I would be very happy, but I will also comment a little bit on these excellent comments, Quan, because we do have so many information in this case. We had the CT angio, which actually depicted the territory of the two branches.
Yeah, that's the question. Please hold on for the second.
Okay.
How do you estimate the myocardium of jeopardized in multiple branches? So you used CT, and how you interpret that one?
Well, I'll show you in a minute.
Okay.
There's another thing here. The patient has no angina at all after this.
Perfect.
So there's not an ongoing thing. But let's move on and see the final result.
Move on means remove the wire.
Yeah. Because here you have the CT scan, the before and after, and the final result on the right, and the CT scan on the left. And actually, it's intuitively pretty easy to take a look on the CT scan and get an idea of how much myocardium is actually supplied by the different branches. And you can see the third branch is extremely small.
Yeah.
Okay. The second one is, I guess, below 10%, and it's not taken just by eyeballing, but if you look into the ARC definition bifurcation paper, there is a very well described series of studies, actually from Professor Coe and his group, showing us how do we estimate the diagonals out of CT scans.
So if side branch is more than 2.5, longer than 73, the myocardium at jeopardize is more than 10%. Is that correct? This is actually the comment from Harris, for whom I really cannot thank enough for being so active and putting so many nice questions.
Yeah, so that is actually one of the rules of thumb for estimating the side branches. But if you make the CT scan evaluations, you may differ a bit because you can have a very long and a very small.
Myocardial mass at least.
Exactly.
Yes.
But there was one thing more we had out of Professor Coe's comments, and that was, even though we measure an FFR of 0.75, which is significant, it may not be clinically significant.
Yeah.
So we may not be totally helped by the FFR value. And again, the last thing is that when we can see that there is a change in the geography around the takeoff of the side branch after we have been doing the POT. And that could be edema, and that could be a bit of plaque shift that may decrease over the first
couple
2
of
weeks.
days.
Yes.
Couple of criticisms, sorry. Should we post-dilate distal part of the stent or do POT alone?
In this case, it was POT alone, but it was a triple POT, actually. So
no, distal stent, distal from the second diagonal.
POT alone.
POT alone. Okay. Side branch lesion length very small according to definition criteria. So just for being sure, we should go on with upfront one strategy, provisional, right? Yes?
Yes.
Is opening the stent struts with undersized balloon useful or necessary to facilitate future interventions? That's a good question and very frequent one.
And the answer is that we don't know.
Thank you very much. Jacek?
So for me, if I go for kissing balloon inflations, I would rather use the balloon appropriately sized for the side branch, because otherwise...
But the question is, should we just touch with 1.5?
No, with undersized balloon, I would never go.
Yeah.
Dr. Koo, final comment from your side.
Yeah, so I don't think 1.5 may be helpful, so that the
diagonal?
So, no, at this stage, no.
At this stage, no. So 3 times no.
Yeah.
Okay,
So,
and would FFR give trustable results in osteostenosis? Dr. Hassan Tokdil.
well, it's difficult to answer.
Dr.
I believe that what is important is to always remember about the pullback, pressure pullback, which is now more and more useful to discriminate between diffuse disease and just the focal disease, because sometimes we see this stenosis in the ostium of the side branch, which is 50-60%. FFR value is below 0.8, but then you do the pullback and you see that majority of this is from the proximal LAD diffuse disease. So this is very important to remember about the pullback.
Final comment before, there is one well done, but I will keep that for later. Harrison Go, with drug-eluting balloon available, perhaps better strategy would be DEB, these branches with significant stenosis. Any data supporting this strategy? Thanks. No data, except
no
for
data,
the study of...
but a fascinating idea.
Fascinating idea.
Yeah.
We all like and we really discuss the role of DCB, but except for a couple of studies with so far very difficult comparisons, and Professor Chen, DCB study after POT and compromise, we don't have really large evidence, and we are collecting evidence. As soon as we have it, we'll share it with you. Now it's time to say, well done. Thank you very much. No, really, a great decision making. So kissing was not considered because we have 3 branches. After POT, result looked even better than before POT. TIMI-3 flow, we see angiographic stenosis, but no angina, TIMI-3, and no ECG changes, no pain. So procedure finished. We will keep following this patient.
Exactly.
Second case is a little bit more complicated. Okay, final comment? Nope.
Yeah, well.
You never know what is enough unless you know what is more than enough. Very good. Let's see what is enough in left main. We switch now to left main.
Thank you, Goran. This is my disclosure. And the case I will present today is quite complex. This is a 67 years old gentleman with typical risk factors. And this patient was admitted to one of the cooperating centers in our region in south part of Poland with non-ST elevation, myocardial infarction, and acute heart failure with pulmonary edema. After the patient was stabilized with pharmacotherapy, he was then transferred to the cath lab for immediate coronary angiography. On the lab test, you can see the mild anemia, renal function is good, and elevated high-sensitive troponin and elevated NT-proBNP in the beginning. This patient was treated before for hypertension, and also there was the heart failure with mildly reduced ejection fraction recognized with ejection fraction 45%. But at admission, the ejection fraction went down to around 35–40%. So this is the right coronary artery with quite diffuse disease in the middle part and the distal part of the artery, which is quite tight, especially in this projection. And of course, in the left coronary artery, we have even more diffuse disease in left main and LAD, tight stenosis in the left main, and also another lesion in the bifurcation of LAD and diagonal branch. So multi-vessel disease involving left main in the patient with non-ST elevation myocardial infarction. The operator performing this angiography decided to stop and to consult the patient with a cardiac surgeon. Of course, the Euro score was quantified as 3.34. The syntax score was 31, and according to syntax score 2, both treatment options were available. What was most important for surgeon was the patient was with recent acute MI, hemodynamically unstable, and also with ongoing infection. Erysipelas of right lower limb was another issue not to operate this patient, and the final decision of the heart team was to qualify for high-risk PCI with percutaneous left ventricular assist device support. So we did CT angiography to assess the access site for impella insertion, which was quite straightforward. So we introduced the impella device, and we started with the right coronary artery. We did a procedure like we do in majority of our complex cases with right radial approach. For the right, it was Judkins right, supported by extension guide, and we implanted 2 overlapping stents in a distal in the mid part of the vessel. Due to the proximal dissection, we finished with the short first stent, and we achieved a good outcome of this PCI procedure. So we immediately switched for the left coronary, which was, of course, much more difficult, much more complex, and the main reason to do this procedure with impella support.
Yeah, thank you. I think we should stop. I think very nice anatomy that we can discuss together. Please join me here in front of the smart board. I like very much the steel frames because you take 2 orthogonal projections, and at least for myself, I would say I learned so much if I know plug distribution, left main, non-left main, bifurcation, lateral wall, how you interpret these images?
For sure, we have diffuse disease in the left main. When you look on the diameter of left main, it is less than guiding, which is 2.4. This is 7 French guides, so around 2.4 millimeter. So it is less. What is also important, there is another stenosis in the ostium of the LAD, and diffuse disease approaching also the first diagonal branch bifurcation. The diagonal ostium looks good. The disease is mostly in the LAD. What is good for this procedure is that, according to angiography, ostium of the CERG looks like it is not involved. So even with the severe stenosis, the ostium
if we make it bigger,
yes.
Yeah, we can make it bigger. Can I take this one?
Of course.
So for me, this is the vessel contour.
Yeah.
CERC, LAD, and actually almost all plaque is here.
Yeah.
So if I go simple crossover stenting, I will compress this plaque without jeopardizing the CERC. Am I right?
It should be, yes.
And there is another lesion. Let's make this one smaller. There is another lesion in the LAD that we also need to treat.
Yes. And according to these projections also, it looks like the ostium of the diagonal is not so bad. The disease is mostly in the LAD. However, what is the difficult for this procedure, we probably need to treat both bifurcations.
Okay.
Left main LAD circumflex and LAD diagonal. What would be your sizes for your stent? Distal LAD or mid LAD looks like it's even less in diameter than guiding, so less than 2.5, very small one. Proximal LAD also looks like the vessel which is not big in diameter. And of course, the left main, we can assess. The ostium of the CERG looks like 3.0. If we count this proximal LAD 3, it would be together 6. 2/3 of this is 4, 4.5 maybe.
4, maximum 4.5.
Yeah.
But you know, with expert for imaging,
Yeah.
please don't tell me you don't have IVUS done in the left main PCI. So
Because we have a lot of questions, and of course we can expect what is the, can we see the slides?
can we go
maybe?
back to slides, because we will come back to smart screen, but now we need to go back to slides.
As you said, of course, nowadays, if we do left main PCI, especially complex left main PCI, we should do it
After
with
ESC
intravascular imaging guidance. So this is why I decided to follow this, which is my practice for many years, to be honest. However, because we have two tight stenosis in the left main and LAD, I wanted not to compromise the flow, so I pre-dilated with the undersized balloon, 2.5. And this is the image. The left main, you see the huge plaque burden.
Yes.
If you go from aorta to the left main. And then I did a pullback. And you can see the diffuse disease, which was also expected by you, Goran, in the proximal part of the LAD involving the ostium, but the CERC is wide open.
Yes.
So this is the confirmation. However, it is always good to
go back
analyze
to
particular cross sections which are the most important for our procedures. So first of all, when you see the intravascular imaging of the mid part of the LAD, it is not so small vessel.
Yes.
Because it is like 2.75 at least in diameter according to the lumen. On the bifurcation with diagonal, we have a confirmation that this diagonal is widely open. The ostium is not so compromised.
Yeah.
Then we move to the left main. As I mentioned before, this is a big vessel. This is more than 5 millimeter left main with a huge plaque burden. And on the bifurcation side, you see, of course, this ostium of the circumflex, which is also wide open, so it is relatively healthy. So according to this, we have exact measurements of the diameters. We know which sizes of stents to be used, and we have confirmation that the provisional strategy should be probably
one long
the
stent
best
or
one.
2 stents?
2 stents. I will use 2 stents because
Okay.
for the distal reference after the diagonal, we need to implant. My choice was 2.75. I will show you, and it would be not possible if you use one long stent up to the left main. It would be not possible to oversize in the left main.
Because of the maximum expansion capacity.
Up to 5 millimeters.
Yes.
Yes.
Excellent. Let's go back to the case and then to questions.
So, as I mentioned, the first step was, of course, the stent implantation across the diagonal branch, 2.75, 14 millimeter long Zotarolimus eluting stent was used. And then I post-dilated with 3.25 balloons. So I did first the pot in the proximal LAD, and I also dilated the left main. And then, according to the measurement of the proximal LAD, I choose 3.5, 22 millimeter long Zotarolimus eluting stent, and my intention was to overlap with the stent in LAD and cover also the ostium. So to appropriately position the stent in the left main, of course, we use epicranial or LAO cranial projections, or both. With the more patients coming after CT scan, it would be much more easy because we can assess the projection based on CT scan. And this is the stent implantation. And afterwards, because it was relatively easy, I pushed a little bit this balloon forward and did another pot with diagonal. This balloon was 3.5. And of course,
a little bit oversized, no?
No, it was not. According to IVUS, the proximal LAD was just 3.5.
Okay.
And this is the pot which I did first with non-compliant 4.5 short balloon, starting from the ostium, and then going to the distal part and position the distal marker at the carina level. And this is the result. I was not very happy with the distal left main, so I removed the wire, which was, as you have seen, it was just the loop. So I didn't want to post-dilate with 5.0 balloon with the wire in the side bench, but the result in the ostium was good, so I felt comfortable to remove the wire and to do another pod with 5.0 semi-compliant balloon. And this was the result of this procedure, which looks quite good. And even I thought it would be enough for this patient. And this was not my original plan to continue with the kissing. However, as for all left main PCI cases, I do IVUS afterwards, and this is the result. The distal edge of the stent, which was across the LAD diagonal, is very well positioned in small plaque burden, very well open. Now you see the side branches with the good flow and good pot, because the lumen area in the proximal LAD becomes much bigger. But then the circumflex will approach at 5 o'clock, and we can see that maybe, Goran, you were right that this balloon was too big, because we see the carina shift.
You
and
see
this
the carina
also,
shift now,
yes,
and you see that it's shifted towards the circle.
This compromised the ostium of the CERG, even with this good angio result. According to the left main, I believe that it was not perfect for the ostium of the CERG, and this is why I decided to rewire to the CERG. And what is not very routine, I did another pullback across the stent, and you see now that this stent implanted in the left main LAD compromises the ostium of the side branch. So this is why I decided definitely to go with the kissing after sequential balloon inflations, 3.0 in CERG and 3.5 in LAD. I did the kissing. The overlap was maybe a little bit too long, so I finished with repot.
I'm trying to find something to criticize.
Yes,
in this
of course. I can also criticize myself. Non-compliant balloon, 4.5, 12 millimeter, and this stage it was at 18 atmospheres, and this is final result. Prox LAD looks the same, but have a look at the bifurcation, which is now much better. We see maybe a little bit of metallic neocarina, but the opening of the struts towards CERG is perfect. We have everything covered, and the lumen area in the distal left main is better. So To summarize the differences, according to IVOS, between what we had before and after KISS in LAD, I believe it didn't change so much, but what is most important is on the bifurcation side, because we repositioned this neocarina, we opened the cells towards SERC, so we protected possible future interventions on the SERG in this relatively young gentleman. But of course, we have created a little bit of metallic neocarina. For the distal left main, it was also beneficial to do kissing balloon inflations because we have increased minimum instant area in the distal left main, which is very important. However, with this eccentric lumen, which can have not the negative impact on the flow.
You did report.
Report was done.
But
this is after report.
You see, it was not really
still eccentric.
Corrected after report. But should we really stick that much with this? It's not really circular, it's a little bit oval shape. Polygon of confluence is oval shape anywhere. If we do CT, many areas have oval shape. So we don't have clear evidence that it's mandatory. But if you use imaging and when you see it, of course, inclines to perform final report.
I believe that it is perfect if you have this circular shape and a good lumen. But I believe also that it is better to have bigger lumen, even in the price of more eccentric lumen, especially in the left main.
Fantastic case. Now, few minutes for questions. We need to go back to our colleagues. There are many questions. Serob Makunian, sorry for off-topic question. Is routine post-dilatation after coronary stenting proven positive impact on long-term outcome? Yes, Colombo made career on post-dilatation in 1995. The most important interventional article ever is image guidance and post-dilatation to optimize the result and the outcome. So always post-dilate. You will not make mistake in the main vessel.
There is one comment on that, because the pod is also for the potential bottleneck. If we have a geographical miss of the proximal part, we will have floating struts.
Yeah, Jens, two short questions. We need to come back for you. How much dissection regarded is acceptable and not needed stenting if the ostium has dissection after kissing? Dr. Zaran is asking. I think it's very accepted. A and B are considered acceptable, and C or more should be taken care of. Federico Arciletti, would you consider kissing pre-dilatation, Jens, in Medina 111 to try a last chance to avoid two-stent strategy or to favor the following steps? I personally don't do it. I don't like, without stenting in the main vessel, kissing balloon pre-dilatation, because if you adequately size balloons, you always oversize in the proximal part. You risk the dissection, and having position of carina in this or the other direction before stenting does not really influence the next steps, because when you stent crossover the main vessel, you will shift carina anyway. And that one you need to correct with pot plus minus side branch interventions. So I'm not in favor. What do you think?
Totally agree. Totally agree.
Okay. Dr. Zaran is again asking, is there different strategy for kissing to remove main vessel stent struts, jailing side branch ostium, then modifying the plaque at the polygon of confluence? Is it useful, and how to differentiate it between jailing strut and plaque shift? I'm not sure that 100% I understand the question, but the sequence of kissing is actually always the same. Try to recross the most distal strut, and then by inflating you remove metal jailing the ostium of the side branch, whether it's circ in the left main or diagonal. And you also, of course, compress the plaque and redistribute the plaque, because plaque will not disappear. It will be redistributed within the vessel. To prepare the lesion, provisional stent to proximal LAD, yeah, this is already the second case. I wonder the sequence of stenting proximal to distal. Why not from distal stent first, then proximal stent to left main? Any benefit? But I think you did.
I did first the distal stent and then the proximal one. But this depends on the patient, because sometimes, you know, when the lesion is diffuse in LAD, and but not so tight, and I have very tight left main, so I first fix the left main and then go for diffuse LAD, especially if I need to do something more than just balloon predilatation. You can use extension guide across the stent in the left main and continue even with rotablation. So this depends on the patient.
Again, would too aggressive kissing balloon cause proximal stent deformation? Yeah, if you oversize, and if you, especially it's important if you overlap in the long segment proximally, because when you inflate two balloons, it's very difficult to avoid twisting of the balloons, and that twisting really enlarges this diameter in the overlap area. So with POT, we take care of the proximal part. With kissing, we take care of carina and polygon of confluence. That's why, and I will show in my presentation now, how to optimally do the final kissing balloon inflation. So this is from the Visible Heart Lab. You see the sequence. We start with the side branch first, then we inflate the main vessel. We always use, for kissing, two non-compliant balloons, both sized according to distal reference of the both branches. Short proximal overlap. If longer overlap, consider repot. Sequential inflation starting with the side branch but simultaneous deflation. And we try to keep balloons for at least 30 seconds or 3 times 10 seconds. If we do short inflation of 10 seconds, we actually lose the benefit of kissing because of significant recoil. And this is 3D OCT reconstruction, and on the other side you see proper kissing through the distal cell recrossing. This is the position of carina, and this is opening of the side branch, and this is the area of the main vessel. So we use kissing balloon in this area to reproduce original fractal bifurcation anatomy using tubular stent. So we create two different diameters, bigger proximal, smaller distal, with wide opening towards the side branch. And I think it's very important to understand, and when I said in the beginning, kissing is sensitive. If you cross proximally, like in this case, and I'll help you to understand, this is the orifice of the side branch, and look, this is a long metallic neocarina created by proximal recrossing into the branch, and then by kissing balloon inflation. So this proximal crossing, and I think that you also at the end, Jacek, had short metallic neocarina. It's sometimes unavoidable, but we should really try to repot, and after you see this on OCT, so repot, try to recross distally and do second kissing, and absolutely mandatory use intracoronary imaging if you want to achieve beautiful result that we had in 2 cases today. The last question from Dr. Zaran, is kissing balloon size different if target is to remove plug shift rather than metal strut? No, kissing balloon diameter is always the same. Reference value of the distal daughter vessels, main vessel, and the side branch, NC balloon, especially for the side branch, because by increasing pressure we try to avoid enlarging the balloon above the selected diameter in order to reduce the risk of dissection of the side branch. So kissing provides really fantastic result if it's properly done. But if it's not done properly, this long metallic neocarina can be potentially nidus for events in the future. So dear friends, especially Prof. Ku, Jacek and Jens, thank you so much for fantastic webinar. And I thank you also, all of my colleagues, for these wonderful questions. We need to exchange, we need to learn from each other. And I also would like to thank the Medtronic for organizing again 3 webinars this year. So this is the first one, and in February and March we will have additional webinars, and on PCR Online you will see the introduction and the team very soon. Thank you very much again, and Happy New Year.